Our second speaker is Dr. Mary Litchford. Dr. Litchford is an international recognized speaker, author, and consultant to healthcare organizations. She holds a PhD in human nutrition, and she was the past president of the National Pressure Injury Advisory Panel. Dr. Litchford is very well known for her ability to translate nutritional concepts and science into real-world solutions for practitioners and patients. And the topic that she will cover is the role of proteins in preventing protein malnutrition and sarcopenia in dysphagic patients.
I'm Dr. Mary Litchford from the United States, and today I'm going to be talking about the role of proteins in preventing protein malnutrition and sarcopenia in dysphagic patients. Now, Albert Einstein was quoted as saying that education is not learning facts, but it's rather the training of the mind to think. So today we're going to be thinking about malnutrition. We're going to be thinking about the relationship between protein malnutrition and sarcopenia, and specifically in individuals with dysphagia, and then that synergistic relationship between nutrition interventions and exercise to promote muscle protein synthesis. Now, nutrition and healthcare are very closely related because health is very important as it reflects your nutritional status. Now, more than 50% of adults worldwide have one or more nutrition-related chronic conditions related to poor quality diet and lack of exercise. Now, the Global Burden of Disease study reported that poor diet was linked to more than 11 million deaths. And what was even more interesting, and that was in 2017, is that poor diet is detrimental to health in individuals that live in countries with plentiful healthcare resources, as well as adults in countries where there are very limited healthcare resources. You see, poor diet is an equal opportunity killer. So let's talk about the trajectory of declining nutritional status. Well, it starts with reduced appetite. Now think about that. For young adults and middle-aged adults, we're hungry all the time. We never have this reduced appetite or anorexia. Maybe if you're sick, you will. But with declining nutritional status and individuals with chronic conditions, and especially those at risk for developing dysphagia, we see this cycle. And so it may be related to a change in taste and smell. It could be medication related. It could be aging related. Isolation, inflammation due to disease or injury, and a loss of muscle strength. And so eating just becomes a very difficult thing to do. And of course, frailty. Well, that leads to declining functional status. So what would that include? That might impair nutritional status, a loss of hearing and vision, a decreased ability to shop and cook, a change in chewing and swallowing, and that would be a wasting of the muscles of mastication. We often see poor oral health, and that leads to other problems as well. Then we see that impaired nutrient utilization. A lot of times that's due to food medication interactions, that the medication either increases the excretion of the nutrient or it impairs absorption. And of course, we see a lot of diseases as well. And so eventually what we can end up with is what I call the perfect storm. Malnutrition, sarcopenia, and dysphagia, the trifecta, those three things together. Now it starts with that declining nutritional status. The person is undernourished, they're losing a little bit of weight, and they're becoming malnourished. And then they have a medical event or some type of a high stress event that impacts their ability to eat, their ability to prepare foods. Perhaps they're in the hospital. They may be NPO for a period of time where they're not getting anything to eat or drink. Their appetite falls even further. We have an increase in inflammation from that medical event, dehydration, all of those things together dramatically increase the risk for dysphagia. Now, the patient may not have dysphagia when they enter the hospital, but that trajectory of declining nutritional status was accelerated because of that unexpected medical event. Now let's talk about what is malnutrition. That's a term that everyone has kind of this vision of, what does that mean? And it's basically a lack of food, water, an unbalanced diet. So it's all carbohydrate, not enough protein, for example. Maybe you have impaired nutrient absorption and digestion. That could be due to surgery, could be due to medications, or you're excreting nutrients more rapidly than you can replace them. It may be due to acute illness or chronic illness or environmental factors, so you don't have food available to you. And it does involve both macronutrients, so that's carbohydrate, protein, fat, and water. Water is the only one without energy. And micronutrient deficiencies, vitamins, and minerals. And nutrient deficiencies will impair normal body processes. So malnutrition is a major risk factor for sarcopenia, because when you're not getting enough food, your protein requirement is higher. And so you're burning more of your muscle mass and more of your protein from your diet for energy rather than to maintain the body. Now, swallowing requires muscles. And when you lose those muscles of mastication, the temporalis muscle around the temporal area, you'll notice that on our screen, and the loss of buccal fat. So you have this hollowed out cheek appearance. And then the loss of that masseter muscle, which is under the buccal fat, that is going to impact the ability to chew and swallow. We know that you can have more fatigue with malnutrition, more frailty, lower physical activity. So perhaps you do less shopping. Perhaps you do less food preparation. Perhaps you only eat things that are pre-prepared, that don't require any preparation or cleanup. You see a loss of muscle mass and function and a decrease in strength of those muscles for mastication as well as for tongue pressure. So who's going to be at risk for malnutrition and nutrient deficiencies? Well, they're really overlooked a lot, I think. This is some data from Europe that demonstrate that 60 to 80% of acute care older adults are going to be at risk of or have malnutrition, and that's based on using validated screening tools. Now, the study in the community was really interesting to me. The numbers were a little bit lower. Greater than 55% of individuals 75 years or older were at risk of malnutrition or were malnourished. But the malnourished were at much greater risk of developing a major medical complication. I think you could add dysphagia to the list. These are just a few from the article. If you look at the data in the US, our numbers aren't as high. And we're not quite sure why that is, but only about 33% of individuals were identified at risk of malnutrition. I mentioned this relationship between energy intake and protein requirement, or nitrogen balance. What the studies that Pellet and Young did back in the 90s showed us was that if you are in negative energy balance, in other words, you're not eating enough to maintain your current weight, the body uses the protein in your diet for energy. And so your protein requirement is actually higher. Now, people with very low appetites often prefer foods high in carbohydrate rather than foods high in protein. So again, that adds to that cycle of declining nutritional status. So how much protein do people eat over the life cycle? Well, this is data from the US. It's from the NHANES study. And what it looks at is how much protein on average do people eat throughout the life cycle and at different decades of life. And so if you look at just the overall bar graph, you see a decline in total protein intake with each decade. The blue bars are for the men, the red bars are for the women. The women aren't as much, you don't see as much difference as you do for the men. Now, what's really important is that the men are consuming less than the basic amount, the RDA of 0.8 grams, but look at what happens when people get sick. Now, this chart shows the percentage of the population not consuming the minimum protein requirement. So the RDA, 0.8 grams per kilo of body weight. Look at the last group of bars on the far right. The dark blue are the females who are healthy compared to that dark orange, females that are sick. What that's telling you is that more than 40% of females 75 or older who get sick are not consuming the minimum amount of protein. Same for the men. Now, we don't see as dramatic a numbers in a little bit younger ages, but it does say to us when people get sick, they don't eat enough protein, and that's when their protein requirement is higher. So let's talk a little bit about protein metabolism. Now, I mentioned that the RDA, the minimum requirement, is 0.8 grams per kilo of body weight. But the better question is, how much protein does the body process every day? Well, the answer to that is around 300 grams. Now, that's not how much they need to eat. That's how much the body processes. So let's talk about that. About a third of that 300 comes from the diet, and 2/3 of it comes from protein reserves. So what are the protein reserves? Well, skeletal muscle is your primary protein reserve, and then the liver, the intestines, and the skin are the other organ systems where you see the most protein taken out of the reserves to meet this 300 grams per day. Now, if you have a wound or you're recovering from surgery, 300 grams is too low. You would use more than that. So you're going to take more out of those reserves. The body takes all that protein from the diet and from the reserves, breaks it down into amino acids, and then those amino acids are reorganized. And from that, we make the body components that are needed. We make the dispensable amino acids. But at the end of the day, everything that's taken out of protein reserves needs to go back to protein reserves. What happens if that doesn't happen? Well, if you don't get enough protein in the diet and you're immobile, got inflammation, you're going to break down more and more protein because inflammation drives an inefficiency in the system so that you oxidize a lot more of those amino acids. So you're not really getting all of those amino acids used efficiently. You're just wasting them. And so that's why it's so important to get enough quality protein in the diet so that you have all those reserves to go back. Because if you don't, then if the energy requirement is not being met, you're going to use some of that protein for energy. You want to have sufficient protein plus regular exercise to stimulate muscle protein synthesis. Now, as we get older, we tend to break down more muscle than we build muscle. And so you're already fighting an uphill battle so that when you add a medical event to declining nutritional status, then we're going to see it's going to take more protein to really counteract that change in muscle protein breakdown. And our goal is to replenish those protein reserves. Now, when we look at protein, we always say good quality protein. Well, what does that mean? Well, it means two things. One is that it contains all of the indispensable amino acids. That's what IAA stands for. And those are on the column on the far left. Now, the amount that you need can be determined two different ways. One is just from a standard amount of protein, our RDA of 0.8 grams, but that doesn't really ensure that you get all of the individual indispensable amino acids. So there is an RDA for each one of these, and I've got it on the third column listed for you, and those come from the World Health Organization. Now, the next column is the quality score reference, and this is what is the minimum amount of amino acids needed in terms of milligrams per gram of protein to be a good quality protein. So you've got to have all the amino acids plus a sufficient amount. So two things. Now I've got some comments in the second column about a couple of the amino acids. If the diet is poor in protein, it's most likely going to be low in methionine and lysine. And so you want to be sure that when you're using a protein supplement or an oral nutritional supplement, that you're providing sufficient amounts of these two amino acids, because otherwise those amino acids are going to be drawn out of your lean mass. And so just keep that in mind. And then the third one is leucine. Now, leucine is an anabolic indispensable amino acid, which means it is responsible for triggering the mTOR pathway, which starts muscle protein synthesis. And a lot of studies have been done looking at how much leucine you need at every meal to really trigger that muscle protein synthesis and optimize muscle protein synthesis. The number that you see in the literature is 2.5 to 3 grams per meal, and that would be about 25 to 30 grams of high quality protein at a meal. So keep in mind the leucine, the lysine, and the methionine when you're looking at protein supplementation. So what kind of interventions do we recommend for these individuals with malnutrition, with sarcopenia, and who are at risk for dysphagia or who have evidence of dysphagia? You always want to start with screening for malnutrition using a validated screening tool. And for all older adults, to screen for frailty and sarcopenia using a validated screening tool. Now, who is an older adult? Well, it depends on which organization you ask. The Institute of Science, Engineering, and Medicine in the US says 51 or older is an older patient. And in other parts of the world, they use 60 or 65 years as an older patient. If the person has any indications of a swallowing issue, then you'd want to do a screening. And the dietitians in the US are going to be trained on doing the screens starting next year. You want to refer to a swallowing specialist if there were any signs of a swallowing problem. And if they are at risk for malnutrition, then you would certainly want to have a comprehensive nutrition assessment and use the accepted criteria to define malnutrition. Those criteria have been established by the Aspen Group and the Academy of Nutrition and Dietetics. And then there's the Global Leadership Initiative on Malnutrition, the GLIM criteria, which are both similar. The next thing is to establish your energy requirements, and that's going to be based on individual assessment. Indirect calorimetry is always the preferred method. It's not available everywhere. And so you would use your predictive equations, or sometimes their range is 30 to 35 calories per kilo of either ideal body weight or actual body weight. I like to focus on food first. I want to provide at least 1 gram to 1.2 grams of high quality protein per kilo of body weight and distribute that 25 to 30 grams per meal. Now, what do you do if the person has obesity? Well, that number might need to be modified. That's where that individual assessment comes in. I would encourage those leucine-rich foods, which are going to be your animal products, and you'd want to have those at every meal because your goal is 2.5 to 3 grams of leucine at every meal or snack to optimize muscle protein synthesis. I would look at fortifying meals with modular protein products if the person is unable to reach that goal, and offer oral nutritional supplements between meals. But again, you need to have a certain threshold of leucine to initiate the mTOR pathway. And so look at how much protein is in the product and how much leucine is in the product. And that information is available from the manufacturers of these products. What about micronutrients? Do we need to add vitamin mineral supplements? Well, if deficiencies are suspected or confirmed, yes, you do. And then, of course, you want to be sure that the consistency is appropriate for the patient. Now, let me give you a comparison of the leucine content in modular protein supplements compared to foods, vegetable sources of protein, because there's a big difference. The first 3 bars, the dark blue bar, the orange bar, and the gray bar, are protein supplements. The first one is whey protein isolate, and then we have a pea protein, and then we have soy. Now, to reach that 2,500 to 3,000 milligrams, or 2.5 to 3 grams of leucine, 30 grams of whey protein will provide around 3 grams. For the soy product, about a little over 2.5 grams. Now, your pea product is a little bit below that. It's a little bit more than 2 grams, but you might have leucine from another source. But look at the kidney beans and the lentils. Now, you'd have to consume 355 grams or 2 cups of kidney beans to get 30 grams of protein. So that might not be your only source of protein in the meal, but look how much lower the leucine content is of the kidney beans in the yellow bar and the light blue bar for the lentils. Now, when we look at methionine, your whey protein isolate is going to be much higher in methionine compared to your other sources. And so think about that as you are recommending modular products to be sure that you're meeting those indispensable amino acids. So what are some of the clinical pearls or the takeaways? Well, number one is that malnutrition can be modified. And, we see sarcopenia and dysphagia as common consequences of declining nutritional status. And if we would focus on prevention of that trajectory of declining status, that would help us before that person actually has a medical event. Because we know that malnutrition and micronutrient deficiencies are often overlooked and they're often misdiagnosed. They are related to acute illness because of the high inflammatory load. And with the high inflammatory load, you have an inefficient use of amino acids. Malnutrition often develops in the hospital or during rehab, but it is modifiable. And so you want to work collaboratively with your medical team to identify and to treat sarcopenic dysphagia.